Okay, so last time we talked about one of the sensory pathways, the pain pathway, and the way we test this is with a safety pin. You just pinprick. That's how you test pain pathway. Can you all think of any reason why pain is a good thing?
It shows your nerve endings work.
With what?
It shows that your nerves work.
Right.
Like evolutionarily wise.
Yeah. So the pain sense serves a very useful purpose because it allows us to get away from, escape from things that could hurt us. And so, like stickers and nails and bites and things like that. So it serves a very useful purpose. Can you all think of any diseases where the pain sense is absent that causes some real problems? Yeah.
Diabetes.
Absolutely. What happens with diabetes?
They kill some peripheral nerve cells.
That's right. Diabetes is a small vessel disease, so what happens is you get what's called a peripheral neuropathy, and so people with uncontrolled or advanced diabetes a lot of times will become anesthetic in their legs, and as a consequence of that, what happens?
Use like cold perception and different things in your feet.
That's right. So somebody that has diabetic peripheral neuropathy a lot of times will get ulcers, infections, bad things that happen partly because they cannot, detect pain. So pain actually serves a very useful purpose. Now the second thing that we're going to talk about, the second pathway, is the pathway for conscious proprioception. And this is a pathway that gives us our stereognostic skills. So what is stereognosis? So Andre, I'm going to use you this time. So I'm going to give you a coin. Now, I don't want you to look at it. I just want you to look somewhere else. But I'm going to put this in your hand, and I want you to feel it. Okay? I want you to tell me what it is. If you can tell me what coin it is.
Quarter.
Okay, you want a quarter. Okay. Now I'm going to give you a different coin. You look over somewhere else. Tell me what that is. You looked at it. You looked at it. Okay. Stereognostic sense allows you. So you won the quarter, but I still get the dime. Anyway, it allows you to be able to feel something and be able to tell what it is without looking at it. That's stereognostic sense. We can localize touch. If you touch yourself, you know where you've been touched. You can feel vibration. We test that with a tuning fork. So, you might. Okay, this is vibration sense. So the way we test this actually is with a tuning fork. You basically just test right and left body. You can test arms, legs, head. So we do that with a tuning fork. Okay, so that's part of what we call proprioception. It tells us how we move. It tells us where our joints are in space, so you can close your eyes and you can tell if your arm is flexed or extended. You can tell where your fingers are. You don't have to look at them. Your brain continuously knows where all of the different joint positions are and actually knows about the tension in all your muscles continuously. And that's part of what we call conscious proprioception. So your orientation with regards to all of your body parts, consciously gives you this conscious proprioception. So this is one of those senses that, because it gives us the ability to be able to have that stereognostic sense, has a very important concept that's kind of associated with this, and this is called two-point discrimination. And so basically what that means is that, like when Andre was feeling the quarter, he could tell how big it was because he had receptive fields that were smaller than the object that I gave him. Now you also noticed it was easier for him to tell the quarter than it was the dime. Okay, so something that has a larger physical extent to it a lot of times is easier actually to perceive. As a matter of fact, you can get to the point where stimulation of 2 points begins to feel like 1 because your receptive field size is larger than the object that you're trying to sense. And so the principle here is that very, very small receptive fields have a very large number of neurons. And so those parts of your body that have more neural innervation will have very, very small receptive fields, and that part of your body which has very few neurons that go to the skin will have very large receptive fields. And so you can imagine, that there is a neuron. This would be, for example, neuron 1, neuron 2, and neuron 3. And so in this case we have 3 neurons that really are kind of over this much area here, and the receptive fields are quite large. On the other hand, I can squeeze that same 3 if I have a whole bunch more into much smaller receptive fields. So I could in this area here, area 1, if I made this over here, maybe have 10 times as many neurons or 10 times as many little areas that the neurons go to, and that gives you better discrimination. So this has good 2-point discrimination, and this has poor 2-point discrimination. Okay? And the way we test this is simply with a compass or with a device where we can just test the whether or not you can sense 2 points or 1 point. It's very simple. If you go to a neurologist, they actually have a set of little calipers, and they can write down in their chart exactly where you can sense 2 points instead of 1 point. Okay, so I'm going to call on Daniel to be my next patient. Come up to the front. So again, on the skin, there are various receptive field sizes. And I need you to take your shirt off. Different parts on his body will have different ideas of this 2-point baseboard with different receptive field size. And we test that just by touching with 2 points, okay? And so what I want you to do is just tell me whether I touch you once or twice. So I'm going to give you an example. That's once, twice. Okay? So you just tell me 1 or 2.
2.
Now don't guess, that was just 1.
Nervous.
Don't be nervous. Okay. What I want you to do is to tell me when you can clearly, tell 2. Okay. You can select. You can tell that. Okay. So you just tell me 1 or 2. Okay. You see how I touched twice and he felt it as once. Okay. So we just keep making this larger.
2.
Okay. So the receptive field size on his back is probably 2 centimeters, something like that. Okay. And so, and that's perfectly normal. That's exactly what it should be. So let's give him a big hand. So we can do this, on your fingers, your forearm. We can, do this 2-point test, and if we do that, we come up with some numbers that we can kind of use as a standard. And so, like your forearm has receptive fields that are about 40 millimeters squared, and then the hand is a little better. The lips are an order of magnitude better, and your fingertips are really good. And that's why when you when you feel something, you don't, put it on your forearm. You take your fingers and you feel it, right? You sample it. So if you had something that you didn't know what it was, and I know y'all have all had this experience where maybe it's dark and you're fumbling, maybe you're fumbling in your purse, you ladies, okay? And you can feel down in your purse and you can figure out, where your keys are, or, where loose change is, right? And so basically you use your fingers to do that. So we can keep on going down. Now, look at the tongue, okay? The tongue is exquisitely innervated. You have extremely small receptive fields in your tongue, okay? Andre? No perverted answers. Why do you have such good 2-point discrimination with your tongue?
You need to taste and manipulate your food.
Okay. Food has a texture. Anybody else have some ideas why your tongue has such good 2-point discrimination? I'm looking at you, Daniel.
You need to take your shirt off for this answer.
Well, I mean, just think. If you're eating, maybe you're eating a fish dinner, and you might like to know if there's a bone, right? Okay, that gives you a huge survival advantage. I mean, you don't want to eat gravel or bones or other things. You go to McDonald's and they maybe have something in it. You want to be able to tell that there's something that you shouldn't be eating. And so that's why we have such good 2-point discrimination with the tongue. But truly, not right now, but when y'all go home, you can test it out. But if you really, really, really want to tell what something is, just put it on your tongue. You can really, really get good 2-point discrimination. Now, the ultimate extension of all of this, if you carry it to the limit, the very best is actually in your retina. In your retina, you have a mosaic of cones, and these cones are spaced very, very close together like this. Okay? And the distance between the two cones, this is like the pixels in a camera. The number of pixels or the distance between two adjacent cones ultimately determines how good you can see. And 2-point discrimination in the retina translates directly into visual acuity. And so if you have poor 2-point discrimination in your retina for whatever purpose, for whatever reason, you're going to have very poor visual acuity. Okay? And so, yes.
If someone doesn't have one of their senses, like they're deaf, usually you hear that they have better eyesight or
Exactly.
better sensory stuff.
Yes. So basically the brain changes the allocation of the real estate depending upon what you use. So this is that principle of use it or lose it. And so somebody that's blind doesn't necessarily get a bunch of new cells in the ear, but what happens is the amount of the brain that's allocated to interpreting that signal increases immensely. Okay, so somebody that has, for example, been born that's blind, their area, their sensory area for hearing and smell will be much bigger than it would be in a normal person. And so your brain, allocates resources depending upon what sensory information that you are giving it. Yeah, that's absolutely true. Yeah.
If you were to lose your eyesight as an adult, would your brain still reallocate resources?
Not as much as if you're born blind. So that's why, a lot of really, really good musicians, were born blind. Okay. So anyway, that's the idea of what we call the receptive field. Yeah.
How do you test the receptive field for the retina?
Well, it's very simple.
Same thing.
When we have, I've been to the doctor's office. We have something like this, right? Okay. I mean, it gets smaller and smaller, and it gets down to where it's like that, right? And then it gets down even smaller where it's like. Okay. Now you can probably see this. You might be able to see that, but probably in the back of the room you can't tell that that's an E. Anybody in the back of the room, can you see that? Okay, that's because if you look at these points here, they subtend an angle, okay? And we know that the cones, in order, like in your retina, the spacing, optimal spacing, the best vision you can get is about 20/10, which translates into 20 arc seconds. Okay? And so if you have an angle which is smaller than 20 arc seconds, these 3 points just look like one. So it's 2-point discrimination. Any other questions? Receptive field. Your ear does the same thing. In the ear, the 2-point discrimination determines how good you can detect tone. And so in the ear, you have tonotopic detection, and 2-point discrimination in the ear translates into tone perception. Somebody has really good tone perception, has really, really good 2-point discrimination in their cochlea. Okay, the central pathway for conscious proprioception is what's called the posterior column medial lemniscal pathway. And this is a fairly simple pathway. Of all the pictures on the presentation today, this is the one that you absolutely have to memorize. So let me kind of go over it so you understand, what the picture is showing you here. Now, we just like pain and temperature, we have these peripheral receptors which are out in the skin. Okay, the action potentials are generated here, so we get a bunch of action potentials. They travel down to the cell body, so they're actually going down the dendrite to the dorsal root ganglia. And in the dorsal root ganglia, the fibers without synapsing split, and they ascend on the same side. So they go up the same side up to the medulla, and in the medulla they synapse in 2 nuclei, the gracile and cuneate nuclei, which I showed you on slide last class time. And at that point the fibers switch over and they go to the other side in what's called the internal arcuate fibers. And so the crossover point for proprioception is in the medulla. And where's the crossover for pain and temperature? It's in the spinal cord at the level of entry. Okay? The internal arcuate fibers then make up what's called the medial lemniscus. Okay, which is a very big white matter tract which goes up through the pons and then through the mesencephalon, and eventually you get to the ventral posterior lateral nucleus of the thalamus. So this is the thalamus here. Okay, and in the thalamus, the fibers then project in the corona radiata to the post-central gyrus. Now remember I showed you last time where the central sulcus is, and I said pre-central gyrus is motor, post-central gyrus is sensory. So this is post-central gyrus of the brain. And so this is a 3-neuron pathway from the skin up to your brain. Are there any questions?
What is the IAF again?
Internal arcuate fibers. Any other questions? Yeah.
You said it went from the gracile and cuneate nuclei to the pons, and then
So the medial lemniscal pathway, goes through, so basically you're crossing over in the medulla, which is just above the cord. And so it crosses over to the other side. And that big white matter pathway is now called the medial lemniscal pathway. And that medial lemniscal pathway goes all the way up on the opposite side now of where it came in, goes all the way up to the thalamus. Thalamus is the great relay nucleus. All of these sensory things are going to end up in the thalamus. And then from the thalamus, then they project on the same side to the postcentral gyrus. Any other questions? Okay. And here's a little more anatomically correct. You can kind of follow the pathway, but basically, your fibers are coming in and they project up to the medulla where they cross over, and from the medulla then through the pons and then through the mesencephalon. This is all called medial lemniscal pathway until you get to the thalamus, and at the thalamus they project through the corona radiata to the gray matter of the brain. Now, the allocation of resources in the brain is in proportion to the receptive field density. And so those parts of your body that have the highest innervation and the smallest receptive fields get the highest get the biggest real estate on the postcentral gyrus. And you can see from the homunculus, that's a cartoon, that you have a greatly disproportionate amount of your brain which is or senses things that are in your face, and in particular your lips and your tongue. Okay, your fingers get a lot more in proportion. Your trunk gets very little. I hope I convinced you that the receptive field size for all of us, like Daniel, is about 2 centimeters. Okay, it's big. Okay, so we don't have much real estate in our brain that's looking at being able to discriminate the shape of an object on our back. If we want to discriminate it, we use our fingertips or our lips or our tongue. That's where we get the best 2-point discrimination. Yeah.
Is the eye on this like the surface of the eye, not the retina?
I'm sorry?
The eye for this?
Yeah, so this has to do with proprioception in the eye, and so this has nothing to do with vision. This is not the visual pathway. This is if you tested 2-point discrimination on the cornea. Okay. Any other questions? Good. That was a good question, actually. Now, how did that information? Okay, this is a good question. So, how did that information from the eye get into the brain? It's going to be different than what I just showed you, isn't it? So, how did the proprioception information get from the eye? Or as far as that goes, the face, how does that information get into the brain? It goes in through which cranial nerve? Fifth cranial nerve. That's exactly right. So the fifth cranial nerve gives you pain and temperature and proprioception, for the face. So it's going to be a different pathway. It's not what we just diagrammed. What I just showed you comes from basically your neck down. Yeah, actually, that's a very good question. I should have covered that. Any other questions? Okay. There's another very important principle, and this principle is called lateral inhibition. Lateral inhibition is the ability to actually use signal processing to be able to refine the signal that's coming in to enhance 2-point discrimination. And so lateral inhibition is a signal processing technique that we've evolved actually to do subconsciously that gives us really much better 2-point discrimination than what you would actually guess you would have just based upon receptive field size. Okay, and it works for all sensory modalities. It works in the eye, it works in the ear, and it works in your peripheral proprioceptive pathways. And so the principle of this is that if this is the surface of your skin, and I touch you with two points here, two objects, 2 needles, for example, you don't just get an impulse function. In other words, you don't get a delta function. What happens is your skin just kind of will bend down a little bit and then kind of bend down a little bit. And so instead of getting a very sharp idea of what that edge was like, you actually get a very blurred edge. It gets blurred out. So what that's called is, it's called spreading of the subliminal fringe. And so any stimulus that you do, any stimulus that you apply to the skin is going to stimulate maximally. If you actually look at the amount of stimulation, you get that Gaussian curve instead of a delta function. And so this basically, your skin is acting like a low-pass filter. Okay? And so our brain, though, has evolved to do some really cool signal processing that actually reconstructs what the real stimulus was based upon a kind of poor representation which is passed along the peripheral nerves that go in. And let me kind of explain here using this diagram here. And so this diagram kind of shows what you might get if I had two objects that were placed over C and E. Okay, well, you don't just get action potentials where C and E are, but you also get this kind of subliminal stimulation of D. And so really, this signal is an aberrant signal. That really doesn't truly represent what just got presented to the surface. And so what happens is that in our projections that go up to the gracile and cuneate nucleus, we have these inhibitory cells which inhibit one and the other. And if you kind of think simplistically, because this one is in the middle, it gets inhibited twice, but this one only gets inhibited once. So if I had a weighting function, I'd get 1 worth weight of inhibition on C, 1 worth inhibition on E, but I'd get 2 worths of inhibition on D. And as a result, when you reconstruct the signal now that goes up to the thalamus, you've decreased this a little bit, but you've decreased this one a whole bunch. Okay, so you've given up a little bit of intensity in order to more faithfully represent the the true signal that came in originally. This is probably a little more elaborate, kind of an idea of the same thing, in that, again, if we have a single stimulus, so this is not 2-point, but this is just one stimulus here. This one stimulus is going to also subliminally stimulate both of these chains, which gets passed down to multiple other neurons that give you a false signal. The stimulus was really right here, and it's looking like it's being spread out. So we have something that maybe looks more like an impulse here that gets spread out like a Gaussian. Now, if we add this lateral inhibition, which is this step right here, basically what we do is we kind of reconstruct what the actual stimulus really was. And so what we're doing is we're high-pass filtering. This is a very elaborate neural network which high-pass filters the information which is going up to our brain. So in electrical engineering terms, this is called a high-pass filter. And you can actually build this using a neural network. And in fact, we do this, and it helps with image processing. So it helps to reconstruct sharp edges. Yeah.
Does the force with which you push affect the resolution?
It does. So you actually get better 2-point discrimination if you don't press too hard. The harder you press, the more peripheral receptive fields you're going to stimulate. Okay. Actually, that's a good question. So the intensity can change actually this processing, because if you don't have an overstimulus, if you don't overload it, you'll actually get a more faithful representation of the edge or the shape that you presented. That's called lateral inhibition. And so again, what it does is, if you have two stimuli, so we have stimulus here, what gets passed into that first part of the brain, really looks more like a single stimulus because of the activation of the subliminal areas around it. And in fact, when you add in the lateral inhibition, which is the transition from this is state 1 to state 2, you more faithfully represent the signal that came in. Okay, so it's a form of high pass filter. Yeah.
Does that also mean if someone presses over a large area, you could also perceive multiple points?
Right. So, if you have a very, very big object that's pressing on you, again, that's not exactly what we're talking about here, because what we're really talking about is 2-point discrimination. So this works best in the context, if you think of it just kind of as a delta function. This would be a touch with a pen, or actually kind of the way that we do it more is actually with a little tiny whisker here. So this is actually how we would test you. So you see the little gadget here? That regulates how much force. So let me show you. See, this is not much at all.
Yeah.
See, if I calibrate this down to a little bit more here, it's a little more forceful. But that's actually how we test it. See, it's a very small point. Okay. Any other questions? So what are some diseases that you might know that affect the posterior column medial lemniscal pathway? Some diseases that you need to know for this class.
Would it be peripheral paresthesia diseases?
So basically, these are diseases that produce the inability to be able to have stereognostic sense, or be able to tell vibration. Again, the way actually we test this is with a tuning fork. So, you know of any diseases that you might have read about where you can't really tell, where something touches you? Well, I'll give you some hints. The first one is B12 deficiency, which is also called subacute combined degeneration. So the B vitamins are very important for the neural function, and B12 is a vitamin which, if you or become very deficient, this is also called pernicious anemia. Have you all ever heard of that? Pernicious anemia. Somebody gets a bowel resection, you don't absorb B12, and you end up with subacute combined degeneration. So the posterior column pathway just degenerates. The second disease that I'm kind of fishing for is associated with the oldest profession in the world. It's not biomedical engineering. Andre, what's the oldest? Do you know what defines a profession? Actually, it's a code of ethics. Daniel?
Motherhood?
Motherhood. You're close.
Or midwife?
No, not exactly. The oldest profession in the world is prostitution. And so the other cause, which is still very, very common, is neurosyphilis, or tertiary syphilis. This is one of those sexually transmitted STDs, sexually transmitted disease. Y'all have heard of sexually transmitted disease, right? Yeah. Neurosyphilis. So somebody that gets neurosyphilis loses the ability to be able to have 2-point discrimination, and they lose the posterior columns degenerate. This is absolutely both of these are treatable diseases. B12, you just inject B12. Has anybody known somebody that had pernicious anemia? It's easy to treat. You just have to give the B12 injections. And how do you treat neurosyphilis? 100% cure rate if it's diagnosed. Penicillin. Penicillin cures it 100%. And believe it or not, we still see cases. I still see cases in my practice every year. People come in because you get it in your eye too. And so I see tertiary syphilis, and it's a 100% curable disease, but we still have it very much in our community. Hard to believe, isn't it? Okay. Any questions? Yeah.
Is there a risk for penicillin-resistant syphilis, or is that not something that?
With which kind?
Penicillin-resistant syphilis, is that
I
something that?
haven't heard of any. I really haven't. Okay, so yeah, it's 100% curable with penicillin. Yeah.
What if you're allergic to penicillin? Is there like no?
Yeah. Well, you have to go to an alternate drug. I mean, they're less effective. Okay. So the receptors for conscious proprioception, again, these are on your skin. There are different kinds of receptors. I think one of the more interesting ones is the Pacinian corpuscle, but you have all of these different kinds of little endings that are all underneath your skin that actually are sensing pressure and touch, and those kinds of stimuli. And the one, it's kind of cool. This Pacinian corpuscle is kind of like a nerve ending with a shock absorber around it. And so it responds to, so if you put a force on it here, it responds as a DFDT. So it responds dynamically. And so, you basically get a spike when you press on it, and when you take it away, it bounces back. But it also responds very well to the tuning fork because it's on and off. And so this is an AC, not a DC receptor. Another one that is a part of this proprioception pathway is called the muscle spindle. The muscle spindle has a linear fiber and a kind of a nuclear bag fiber, but basically what it is you have these mechanical receptors, these proteins in the membrane of the cell, and because you have a cytoskeleton, this actin cytoskeleton, when you stretch it, when you pull on it, it just physically opens the pore. It's a physical opening of the pore, which then can depolarize the initial segment, which then causes a train of action potentials to fire. And so this is a good example of a mechanical receptor. This is a protein channel, which because it's tied into the skeleton of the cell, it just actually deforms and allows ions to flow through it when it gets mechanically stimulated. And these, again, they're located over all of your skin. There are also a lot of these fibers that are around your hairs, so you don't actually have to touch your skin. If you just touch the hair on top of your skin, you can feel that, right? See? You can feel that. Okay, you can feel if you touch. Feel if you touch the hairs. Another diagram which kind of shows how these fibers are distributed primarily down in the dermis part of your skin. They all come in the back side of your spinal cord, right? Okay. So here's a good quiz question. Okay. Now we talked about pain and temperature the last time, but let's suppose that poor old Andre now has that same old knife cut that cuts the right side of his spinal cord at the C5 level. So you have a right spinal cord in section. Now describe for me what the sensory loss is going to be.
No
What is-
pain and temperature on the left side from that point down.
Pain and temperature. Temperature on which side now?
The left side.
Left. C5 down. Now why is that?
Because it crosses over in the spine.
Because it's already crossed over. Okay, I agree with that. So that's the first part of the answer. Now how about the other part of the answer?
Pressure and touch sensitivity is decreased on that same side.
Proprioception on the right side from C5 down. Now look how weird that is. So you lose pain and temperature on the opposite side, but you lose proprioception on the same side from C5 down. That's called a sensory dissociation. It's kind of weird, isn't it? You can't feel the needle prick on the left side of your body, Andre, but you can't feel the tuning fork on the right side. Still feel them. You can still feel when I touch you with the needle, but you can't tell the tuning fork. That's
So I
called.
can feel it, but it's not painful?
You can't tell.
No, so if you poke me, I can feel it, but it won't be painful.
It'll be painful on the right side, but not the left side, right? This is the sensory loss. So what I've described here is the loss. Okay, so you've lost pain and temperature on the left from C5 down because it crossed when it came in, but you lose proprioception from C5 down on the same side, on the right side. So on the right side, you cannot feel the tuning fork. You gave the right answer.
Right.
Okay? All right, so again, that's called sensory dissociation. Any other questions? Yeah?
Does pain desensitize touch? Like if I feel pain for something, will the touch feeling of that immediately go away?
So this proprioception pathway is really, remember we talked about, when we talked about pain and temperature, we had the main pain and temperature, which is the needle here. That's the main pain and temperature. But we also have a secondary pathway, which is light touch and tickle. Your light touch and tickle is more like that. Okay. When we test proprioception is vibration, or proprioception, I can also test it by having you tell me where your arm is. And so if you had neurosyphilis, okay, if you had neurosyphilis and you came up here and I put your arm in a certain position, I said, Andre, is it stretched out or is it flexed? I said, I don't know. Because you can't tell, because you can't, your receptors aren't signaling to your brain. So you can test it by joint position too.
But in the right arm, you'd still be able to feel the prick.
You can still feel the pinprick.
Okay.
Okay. Okay, we have another pathway which is called unconscious proprioception. That's conscious proprioception. Unconscious proprioception is essential for posture and motor coordination. It involves primarily the basal ganglia and the cerebellum, and these are pathways that you should memorize. We have a dorsal spinocerebellar tract and a ventral spinocerebellar tract that we're going to talk about in just a minute. But these basically are tracts that end up in either the cerebellum or the basal ganglia. It turns out that the basal ganglia part of the diencephalon is very important for patterned motion, learning how to do things repetitively, motor skills. And the cerebellum is also a big sub-program. It's a big motor sub-program where all of your really kind of pattern motor skills are kind of stored up in the cerebellum. So you don't have to think about, when you wiggle your fingers, you don't have to think, well, I'm going to flex this one and I'm going to, not, take the tension off the extensor and the flexor and I'm going to do this. You just it's all one motion. It's all program. It's a learned program. Okay. Now, this is tricky. You really better pay attention here because it's a hard concept. But we talked a little bit about the muscle spindle when we talked about conscious proprioception, because the muscle spindle, it does send a large number of fibers in the conscious proprioception pathway. So it is a part of conscious proprioception. It is also a very big component in the unconscious proprioception pathway. And so it turns out that what the muscle spindle is, the muscle spindle is actually a muscle fiber, okay, that is embedded in parallel with the big muscle fibers that we talked about before. Okay, so the muscle spindle is a muscle, but it's also a sensory receptor. That's kind of weird. A muscle and a sensory receptor, all combined into one. Really cool. Anyway, it turns out that the afferent part of the muscle spindle is carried in what we call the 1A fibers. 1A. Group 2 fibers are kind of less important. Just remember 1A fibers. And what they signal to the brain is they signal the amount of tension that's in that little muscle. Now it turns out that the little muscle is innervated by not the alpha motor neurons, but by the gamma motor neurons. And so this little muscle is innervated here, by branches of the gamma motor neuron system. Now the big muscle, which is in parallel with it, here's the old big muscle over here somewhere. That's probably not a good place to put it, but it's parallel. It's innervated by the alpha motor neuron. So we have a gamma motor neuron system that goes to the muscle spindles, and we have an alpha motor neuron system, which is the big, motor unit, force-producing output of your brain. Now, this is what a muscle spindle looks like under the microscope. You can see the 1A fiber here, and then these are some of the places where it's innervated into the actual muscle itself. Now, this diagram tells the whole story. So if you understand this diagram, you kind of understand the concept. And so we have this little guy here, which is the muscle. This is the one we're talking about, the muscle spindle. The gamma motor neuron. Here's the alpha motor neuron. Okay, they're in parallel. So if I contract the muscle because it's in parallel, if I contract the muscle, what happens? If I contract the muscle, I decrease the tension right here, and I decrease the firing in the 1A fiber. If I passively stretch it just by pulling on it, okay, here's the tension. If I just put a step function in tension, I make it fire. So passively pulling on the muscle makes the 1A fiber fire. If I passively stretch, it makes the 1A fiber fire. But if the muscle actually contracts itself, it suppresses the contraction because it's in parallel. Okay? And it turns out that the gamma motor neuron system can be used to, contract this muscle here. So you contract this one, and it can fill in the action potentials that would be absent when the muscle contracts itself. So basically what it's doing here, this is a huge feedback system where your brain is constantly monitoring these 1A fibers to look at tension in the muscle, and it's sending information back down the gamma motor neuron system to bias it. Okay, it's a hard concept. So we have a very, very important receptor, which is both a muscle and a fiber, which is telling us muscle tension. This is what we call the group 1A afferent fibers. Real important information that the brain has to have in order to have coordinated motor function. Okay. This also makes the monosynaptic stretch reflex. Mulia, you want to come up? My next patient. Thank you for coming up. Come up over here. I'm going to get you to gently sit down on that table right here for me. Okay. So, what the monosynaptic stretch reflex is if I go in and I passively stretch the muscle tendon, I create tension in the muscle. Okay, that tension in the muscle is going to be sensed by what? It's going to be sensed by the 1A fibers, right? If I passively, let me go back. Here's the picture here. If I passively stretch, it causes the 1A fibers to fire. Okay? Now it turns out that these 1A fibers have a monosynaptic reflex arc here, which is classic here. So here's my little gamma fiber here. The 1A's here come in like this through the dorsal root ganglia. They synapse directly on the alpha motor neuron. So if I stimulate 1A, I will get the alpha motor neuron to fire. If I stimulate the 1A fiber, I reflexly get the alpha motor neuron fire. And I know y'all have all been in the doctor's office and you've seen the little hammer, you know. And so this is the monosynaptic stretch reflex. You see the test there? See that? And just relax. You don't be tense, okay? You're doing a great job. You don't have to do anything. Just look at the room. There you go. You don't have to do anything. So you see how I'm doing the reflex? Now every single muscle in your body will do the same thing. And so, you know, if I basically, you can see the biceps contract. I don't know if you can feel it. You feel it there? Yeah. Okay. I can do it in the wrist. I can stimulate the wrist. And the idea is that it should be symmetric as I go around here. You know, see it contract here? Let's give her a big hand. So that's called the monosynaptic stretch reflex, and I can test that for the muscle groups around any of your joints. And by doing that, what am I testing? I'm testing the integrity of the
Deregulation.
of the spinal cord. And so, you know, you don't need. So Amelia, I could decorticate her. She could, you know, we could cut her head off, and she would still have these reflexes. Okay. These are all internal to the spinal cord. And the way, sometimes we actually do that with cats, we'll just decorticate them, and then you can study, you know, these different reflexes that are internally wired in your spinal cord. And so by doing this, you know, I can tell the integrity of the monosynaptic stretch reflex and the integrity of the spinal cord. Okay? Any questions about that? Yeah.
What is the purpose of that reflex? Is it just to protect the muscle from overstretching, or?
So, good question. This actually gets into the discussion that we'll go into a fair amount more, but since you raised the question, let me back up for a second here. And let's just suppose that I put a little gamma input here. So let's just suppose that I just my brain just sent a little gamma input into the muscle spindle. What's going to happen to the firing rate on the 1A fiber? If I stimulate the muscle spindle by putting input into the gamma fiber, I cause it to contract. It's a muscle and a receptor.
So it'll decrease.
If I stimulate the gamma fiber, I make it have more tension, which then makes the 1A fiber signal into the brain that it's been stretched. I can passively stretch it, just like I did for Amelia, but what?
Then wouldn't the muscle contract and it would relieve that tension?
Well, it will. Okay, but I'm showing you something here.
Okay.
So if I just put a little gamma input, just a little bit, just pinged it with a little gamma input, I can get a huge amplification. Just think about this. Just a little gamma input now is already automatically connected to the alpha motor neurons. So when I get a little bit of extra stretch in the muscle spindle, as I put a little gamma input in, I can cause the big muscle to contract. It's an amplifier. You see how it works? Because it's all connected in the spinal cord. So a little gamma input gets amplified, and I get a big contraction of the alpha motor neuron at the same segment in the same muscle. Y'all think about that. See how it works? Okay? And so it turns out that we actually have two motor systems that we're going to talk about. We're going to talk about the main one, which is the alpha motor neuron system. That's your conscious motion. But there's another motor system which is just involved with posturing. Okay, the posturing really has to do with these big muscles in my leg. I don't have to have good control over them. My brain would be wasting its time to be sending, really, really perfect signals down to these muscles. So instead, my brain just sends down this gamma input, which controls my posture muscles. Okay? And so it turns out that, in order for me to maintain upright right posture, I really don't have to have my brain work. I mean, if you don't believe it, the experiment classically that we do, again, is we take a cat and we just cut its brain off. So we basically just have a brain stem and a spinal cord, and you can take the cat, you can throw it up in the air, and it'll always fall on its feet. Okay? A cat has absolutely no brain. Okay, that's called a decarticate cat. You don't want to do it for a cat. And so you throw the cat up, and it'll always land on its feet. Have y'all ever done that, where you just throw a cat up?
Not a decapitation.
Cat lovers are going to kill me, but anyway, it is a classic experiment. And so these reflexes are all wired into your spinal cord. You don't have to have your brain participate. They're all part of this gamma motor neuron system. Does that answer your question, Andre?
Yes, thank you.
So this is a good one to remember. Monosynaptic stretch reflex. Next time you go to the doctor and you have a physical exam, the doctor's going to test your reflexes, and this is what they're testing. So do you know some diseases that actually make the reflex be too strong, where you actually, I don't know, we could go around here and test everybody, but if you're really, really stressed out, you got a lot of thyroid hormone, and you do this, your leg, you basically go boop, and it just goes like this. It just actually goes into what's called a colonus. Now, you do this on yourself when you go home. You don't have to have a hammer, but you just take your... Anyway, hyperthyroidism you can diagnose sometimes by just looking at the reflexes. We look at the reflexes right and left, so it's a comparison of how strong they are right and left that gives us some ideas as to the integrity or disease processes that are occurring in the spinal cord. Okay, so there's actually a lot of circuitry here, but a part of the monosynaptic stretch reflex is that we basically have here's the one. I'll draw this out for you. Here's the 1A fiber. Here's the muscle spindle. Here's the 1A fiber, and this comes up and it synapses on the alpha motor neuron. It comes back to the same muscle, and so you stimulate 1A, you get the muscle to contract. But the spinal cord also has a circuit that has an inhibitory neuron, and that's this guy right here, okay, which inhibits the antagonist muscle. So anytime I stimulate this guy, so I stimulate this, I cause the antagonist muscle to relax. And this is important because you don't want to be co-contracting both muscles. So whenever you stimulate the flexor, you're going to automatically inhibit the extensor. Okay? That's built into your spinal cord, so your brain doesn't have to worry about that. All circuits that are in the spinal cord. This is by these inhibitory interneurons, and it works for either way, whichever muscle you look at. There's a reciprocal circuit for the other one. Any questions? Okay. Now the Next category of afferent that you have to know about is the 1B. So that's the 1A muscle spindle. It's a muscle and a receptor. And the other one is the 1B Golgi tendon organ. And these are sensors that are actually in the tendon itself. And so these sensors will sense force. Okay? So anytime I stretch the muscle, or if I contract the muscle on my own, these are going to fire. Now you stop to think about it. That's not the same way that the 1A works. The 1A, if I passively stretch it, it will fire like the 1B. But if the muscle itself contracts, the 1A firing rate goes down. Right? Okay. So you basically are getting a differential input. So it's very important for your brain to know the static tension in your muscle. It needs to know the amount of force that the muscle is producing in real time. Okay, and so the group 1B gives it this additional piece of differential input, which is going to go to the cerebellum and to the basal ganglia in order to be able to have this beautiful feedback loop work that allows us to have pattern motion, pattern movement. Okay, so 1A, 1B. And this is kind of what the 1B fiber looks like in the tendon. So this is actually just kind of like a ball of free endings that gets mechanically stimulated because of the force which is created in the muscle. It's a really important sensory piece of information that the brain needs to have. Now, I gave you a diagram which is in the notes, but it says the same thing, but it's too complicated, so I put this one in. It's easier to understand. And so basically you have this Golgi tendon organ, the 1B fiber. So this is the 1B fiber, which comes in directly into the cord, and instead of synapsing on the alpha motor neuron from the same muscle, it has that Renshaw cell which gives you the negative, gives you the inhibition. So if you stretch the muscle, this reflex, the 1B, will cause the muscle to reflexly relax. Okay, it prevents over contraction of the muscle, so you can think of it as being kind of like a safety net. But in addition, the 1B is sending a bunch of information up to the brain. And so that's the kind of the reflex arc for the 1B that's in the spinal cord. Okay. So this slide kind of summarizes the important things that we, I think, have talked about today. The group 1A from the muscle spindle, the 1B from the Golgi tendon organs, group 2 comes from the muscle spindle, and then we have some smaller neurons which give pain, temperature, chemical sense, and so on. We talked about that, last class time. Okay, those are the main fibers. So this is another diagram that you just have to memorize. It kind of shows what happens to the 1A fibers. So these 1A fibers are going to contribute a large part to the conscious proprioception. So they just basically go up the posterior column pathway. So they're basically going to turn off and go into the back part of the spinal cord. But the new twist here is that these 1A fibers also send information in the dorsal spinocerebellar tract. Now, one thing that's important about the cerebellum, unlike the cortex, everything in the cortex is crossed. So motor and sensory, everything on the right side of your body ends up in your left cortex. In the cerebellum, it's all ipsilateral. So anything from the right side of your body ends up on the right side of the cerebellum. So the cerebellum is uncrossed. And so the dorsal spinocerebellar tract comes in and it synapses in lamina 7 of the posterior horn of the spinal cord and sends a pathway which is in the lateral part of the spinal cord, which goes directly up to the inferior cerebellar peduncle, which then goes to the cerebellum. Okay? So that's what this diagram is the takeaway from this diagram. Okay, that's the dorsal spinocerebellar tract. Second one, that's the 1A fibers. The B fibers, the 1B fibers, they come in and they are going to synapse. They're going to actually cross. So in laminas 3, 6, and 7, these synapse, and they cross over in the anterior white commissure of the card, and they ascend in the card on the opposite side. Okay, it looks kind of crazy here, but these go all the way up to the cerebellum, and they cross back over in the brachium conjunctivum, or the superior cerebellar peduncle. So superior cerebellar peduncle, they go back, and so it ends up on the same side that they basically came in from. And that's called the pathway for the ventral spinocerebellar tract. That's important because we're going to be looking at these tracks when we look at the circuit diagram, for the cerebellum. So now you know where the input to the cerebellum is coming from. Okay, this is the input to the cerebellum. It's giving us unconscious information. I mean, it's both conscious and unconscious, but I should have shown you here. This actually goes up to your, medial lemniscal posterior column pathway too. But this huge pathway, it's big, really big white matter pathway, is going up to the cerebellum in the unconscious proprioception pathways that give us fine motor control. Yep.
You said it crosses over but ends up on the same side?
Yep, it crosses over, goes all the way up to the superior cerebellar peduncle, which is up in the pons.
So
It crosses over and then it crosses back over.
Oh,
So it's a double cross. Ends up on the same side.
where is it?
Yeah, the superior, it's also called brachium conjunctivum, or superior cerebellar peduncle. It goes back over to the same side of the cerebellum.
What's
Yeah.
What's the white matter tract that crosses over the first time?
The the restiform body, or the inferior cerebellar peduncle, but it doesn't cross. The 1A fibers, they're staying on the same side. They never cross over. The crossover here in the spinal cord is in the same as pain and temperature. It's the internal arcuate fibers in the anterior commissure. If you can imagine, I'm sorry, back up for a second. It's the anterior commissure fibers in the spinal cord. So anterior commissure, that white matter tract, same one where the pain and temperature goes over. Anterior commissure. We can, put these ideas kind of all together. I tried to put the 1A and the 1B fibers kind of on the same picture here, so you kind of get the whole idea. And so, we can follow the fibers from the. So this is Golgi tendon, and this is the muscle spindle fibers. But both of these are going to give pathways that go back up to the posterior column. So this is going to be conscious proprioception. Okay, they kind of cross. They don't cross. They on the same side, posterior column pathway. But the group 1A fibers, see, come down here, like this, and they then synapse in 7, and then they ascend on the same side in the dorsal spinal cerebellar tract. So you associate 1A with dorsal spinal cerebellar tract. 1B comes down, makes synapses in 5, 6, 7 in the anterior white commissure, goes up the ventral spinal cerebellar tract, and eventually it goes back over in the superior cerebellar peduncle to the same side. Now, the reason that this is important is because there are a number of motor problems that can be caused by a defect in the proprioceptive pathways. And so somebody, for example, that has neurosyphilis has a very, very severe motor impairment, as is true for B12 deficiency. And the reason is because you don't get the inputs into the cerebellum and basal ganglia. So if you don't have inputs into the servo that's controlling your motor function, you're not going to have smooth motor function. And we'll go over, and when we start talking about the cerebellum, we'll talk about the different syndromes that affect these various inputs and the various nuclei in the cerebellum that determine these abnormal motor kind of functions. So you all become very good diagnosticians by the time this class is over. Are there any questions? So we have now covered pain and temperature, conscious and unconscious proprioception. We're going to end right there.
What do the numbers in that graph signify?
Those are the lamina. Actually, that's not important for this class. You don't have to know that.
Okay.
So those are just called basically it's just different places. This is the posterior part of the gray matter of the spinal cord. Y'all have a good weekend.
So do you